congratulate Ajanta Pharma for this wonderful educational initiative. I'll be taking you through certain clinical examples where things may look like glaucoma, but they turn out to be something different. In a busy clinic, you see everything gray, everything looks like primary angle closure glaucoma, everything looks like neovascular glaucoma, in the middle of which would be hidden something that is sinister. And if you recognize a key feature in some of these, then you'll be able to pick this up and not endanger the eye and vision of these patients. These are some of the clinical scenarios where other diseases can mimic glaucoma. Angle closure, appositional infiltrative, outflow obstruction, depository or infiltrative, hypopyon and hyphema associated with glaucoma, neovascular glaucoma, and elevated episcleral intravenous episcleral venous pressure and combined mechanisms. For example, this is a patient with peripheral shallowing of the anterior chamber, but you see that it is sectoral and it is bumpy. In such patients, you expect that there would be a cyst behind the iris, and if you do a UBM or ASOCT, you should be able to pick up that it's a simple cyst which is causing appositional closure, and sometimes that can be very critical. Another example is an infiltrative angle closure glaucoma. This looks like a cyst from the front, but not to miss this solid lesion. That is a cyst, that's the solid lesion, and that happened to be a melanoma infiltrating the anterior chamber angle, thus causing glaucoma. Now, outflow obstruction can be caused by a benign tumor. This is melanocytoma. It's a charcoal dark tumor with no NVI at all, but high intraocular pressure because of the deposit of the pigment that is released by this very fragile tumor, that's melanocytoma. It's nothing but a magnocellular nevus. It's a benign lesion, but can cause high IOP, and for this patient, of course, trabeculectomy is indicated. Whereas this patient may look like angle recession. It's a wide ciliary body band, but it is not. This patient has a ring melanoma of the iris and trabecular meshwork, and that can cause secondary glaucoma. This patient was misdiagnosed as iridocorneal endothelial syndrome because of correctopia and ectropia on UVA this patient had. But behind the iris, you see a dark pigmented mass, and that's a melanoma. This patient has actually undergone a trabeculectomy with a curiously round PI for whatever reason. But when we did enucleation, you find that his under the scleral flap there was infiltration. The bleb itself was infiltrated, and that's the melanoma that was lying behind the iris. So young individual coming with a secondary glaucoma which may look like ICE syndrome, if you have any doubt at all, you should do anterior segment imaging. A 60-year-old male presenting with hypopyon, but the eye is white. Hypopyon with secondary glaucoma, eye is absolutely white. In a white eye hypopyon situation, you must suspect lymphoma leukemia. And in a child, 5-6-year-old child with hypopyon with secondary glaucoma, you must suspect retinoblastoma. And it could be a peripheral retinoblastoma, not very clearly visible. And also in 4 or 5, 6-year-old children presenting with anterior segment seeds like this and secondary glaucoma, you should suspect medulloepithelioma. Metastasis can look like granulomatous uveitis with hypopyon, but can have glaucoma as the component. In children who present with occasional hyphema with glaucoma, of course, juvenile xanthogranuloma should be suspected, and a very important clinical tip is to look at their body. On the trunk and abdomen, they will have this macules, and that's diagnostic of juvenile xanthogranuloma. This was a 14-year-old child who had a blunt trauma, and she presented with hyphema with very high intraocular pressure, not responding to conservative medical management. She was already on oral steroids. When we did imaging, we realized that the iris was actually thickened, and traumatic hyphema, that is definitely not going to happen. Her peripheral blood smear, bone marrow biopsy, systemic survey were all negative because the child was already on steroids. We know that in leukemia, if the child has been started on steroids, the peripheral blood smear can be negative. In this patient, iris biopsy could establish the diagnosis that she had AML. This was a 6-year-old girl who had a history of trauma. You can actually see there is a small lid laceration, and she's a full chamber hyphema. This was drained by a glaucoma specialist. He did do a B scan before he drained it, but what was missed was this calcification. Several months later, the child presented with extraocular extension of retinoblastoma which she had. So trauma here was incidental. Hyphema resulted from a pre-existing tumor, and that was drained. So enlarged cornea simulating congenital glaucoma can occur in retinoblastoma. This child had bilateral retinoblastoma but looked like congenital glaucoma, and this is a child with unilateral enlarged cornea with retinoblastoma. Neovascular glaucoma can happen because of tumor vascularity itself, VEGF that is released by the tumor, and central retinal vein occlusion. This is a patient with medulloepitheloma, adult onset medulloepitheloma, not to miss the neovascularization and high IOP here. This is a patient with a small melanoma right on top of the optic nerve head causing neovascular glaucoma. Such a small melanoma generally does not cause NVG, but this patient has optic nerve infiltration causing central retinal vein occlusion, because of which she had developed neovascular glaucoma. In phacomatoses, almost all these can have high intraocular pressure, such as patients who have Sturge-Weber syndrome with diffuse choroidal hemangioma and secondary glaucoma. Patients with neurofibromatosis can have trabecular dysgenesis and glaucoma. This is a patient with Lisch nodules. Nevus of aorta or oculocutaneous melanocytosis can have glaucoma as a component, but not to forget the fundus. They have a dark colored fundus from which occasionally they develop a melanoma. This is a patient who developed melanoma and needed enucleation. So in conclusion, I would say that there are certain complexities in patients who have a tumor as well as glaucoma. You should never do a penetrating glaucoma surgery in patients who have a tumor unless you confirm that it is indeed a benign tumor. Medical management of glaucoma and or laser procedures are acceptable in such situations. Inadvertent intraocular surgery can actually predispose them to extraocular extension and metastasis. So thoughts for the general ophthalmologist is that if you are aware of atypical clinical features such as unilateral glaucoma in a young adult, you should definitely investigate. If you have anterior segment imaging for iris and ciliary body lesions, then you may not miss that there is an underlying tumor. All children with glaucoma should have a B scan for sure, and also an immersion B scan if you're suspecting medulloepitheloma. All hyphema and uveitis where fundus view is unclear should have imaging. And all unilateral neovascularization of the iris and neovascular glaucoma where the etiology is unknown, they should also undergo imaging. So imaging is the key to diagnose an underlying tumor in the presence of glaucoma. Thank you so much.
Thank you so much, sir. I think it's an eye-opener that when you're thinking of glaucoma, please keep the possibility of secondary glaucoma and something more sinister in the eye.